Assalamualaikum warahmatullahi wabarakatuh dan salam sejahtera. Kita mulakan program kita pada hari ini dengan Ummul Kitab Al-Fatihah. Terlebih dahulu, unit latihan Hospital Al-Sultan Abdullah UiTM ingin mengucapkan selamat datang kepada penceramah kita pada hari ini iaitu Profesor Dr. Jamiyah Hassan, Pakar Fetomaternal Jabatan Obstetrik dan Ginekologi, Fakulti Perubatan dan Hospital Al-Sultan Abdullah UiTM. Beliau akan menyampaikan taklimat mengenai Beyond Cervical Cancer, HPV Vaccine for both men and women. Selamat datang juga diucapkan kepada semua warga UiTM yang sudi meluangkan masa untuk taklid taklimat pada hari ini. Moga taklimat ini dapat memberi maklumat dan manfaat kepada semua warga UiTM. Baiklah, tanpa membuang masa, dijemput Prof untuk menyampaikan taklimat beliau. Sekiranya ada pertanyaan, tuan-puan boleh type di ruangan chat untuk dijawab oleh penceramah kita nanti. Persilakan Prof.
Bismillahirrahmanirrahim. Assalamualaikum warahmatullahi wabarakatuh. And a very good morning to everyone. Thank you very much, Fazira, for that kind introduction. Today, I'm going to speak about cervical cancer and how this HPV virus can affect both men and women and how we can combat or do a preventive strategy. Saya akan memberi ceramah ni dalam bahasa Inggeris, tetapi saya boleh juga menjawab segala soalan di dalam bahasa Malaysia kemudian. For the next 40 minutes or so, we're going to learn about what is HPV virus. And I'm going to introduce to what is human papillomavirus, which is said HPV. Then we'll look at the consequences of this HPV virus infection in both men and women. But majority of the HPV virus infection is on the woman, which is in terms of the burden of cervical cancer. And we'll look at the prevalence of HPV virus in Malaysia. We look at some of the data, some of the research that's being done, and we focus on some of the preventive strategies, and then look at the real world data into the effectiveness of HPV vaccine, and I'll summarize from there. So let's see, what is HPV virus, which is human papillomavirus. Now, this is a human papillomavirus tree. So if you look at this tree, there's so many branches in this tree. So currently, there are more than 150 subtypes of HPV virus, but not all the subtypes are important. So the important subtypes are here, the one you see in dark brown, which is called high-risk HPV virus. Why is it called high-risk? Because they can cause cancer with persistent infection. So in this group here, you can see high-risk HPV virus, which is subtype 18, 45, which in the same tree here. And the other large group is, you see here, HPV 16, 31, 35, 52, 58, and you also have 33 here. So this is called high-risk HPV virus. Now in the light pink here, you have two subtypes that's very important, which is subtype 6 and 11. Why is it important? Because this causes genital warts. So let's see how this virus can affect men and women. Now this virus is not new. It has been discovered way in 1970s by this guy, Dr. Hassan, in 1970s. He won a Nobel Prize for it. So HPV virus is a DNA virus. So it's more than 150 subtypes, but only about 12 to 15 high-risk HPV virus that cause cancer. So how do you get this HPV virus? So mainly just through sexual intercourse. So every one of us, if we are sexually active, about 80% of both male and female will be infected with HPV virus throughout the lifetime. But not all of us will have a problem. More than 90% of us will combat the virus. So the virus will go away, your own body system will clear the virus. But about 10% of men and women will not be able to clear the virus. This will lead to persistent infection. Now, the word persistent is very important. Persistent infection means continuous infection. And when there is persistent infection in certain type of high-risk HPV virus, these can lead to cancer. So not every virus leads to cancer. Let's see which virus leads to cancer. So the main burden of HPV virus is causing cervical cancer. We know now almost 100%, close to 99.9% of high-risk HPV virus cause cervical cancer. Let's look around the world. So I said just now sexual intercourse is the main mode of transmission. So let's say around the world, is it the same? So you see here in Americas, North and South and North America, in Europe, in Asia, Southeast Asia, where we are, you see it's all the same. So the most common HPV virus is 16 and 18. Now 16 and 18 cause more than 70% of cervical cancer to women, but it also cause more than 70% of an anal cancer to men and women, and it also cause penile cancer to men. But you look at the other subtype here, 45, 31, 33, 52, 58, with an additional 5 subtypes adding to 16 and 18, these will cause almost 90% of cervical cancer due to HPV. So you see here, cervical cancer due to the 4 subtypes, 16 and 18 is 70%. If you add the other 5, it's more than 90%. If you see anal cancer here, the 5, the 7 here, 16, 18, 31, 33, 45, 52, 58, to men and women cause more than 90% of anal cancer. But I look at genital warts here, 6 and 11 cause more than 90% of genital warts. So when you look at it in the nutshell, HPV virus not only cause cervical cancer, a woman, so you see here the burden is very high, almost 100%. So in medicine, we doesn't like to say 100%. We always say 99.9%, but it's almost 100% of HPV virus cause cervical cancer. But you see here, it can cause anal cancer for both men and women. It can cause penile cancer for men. It can cause oropharyngeal cancer for both men and women. And it also can cause vulvar vaginal cancer. And in genital warts, more than 90% of genital warts are caused by HPV virus. So this is the causation of HPV virus to cervical cancer. Now let's look at what is the global estimate of newly diagnosed HPV-related diseases for both male and female. So you see this pyramid here. Mainly new cases are still the genital warts around the world, and in Malaysia it's the same for both men and women. And here, cervical cancer, 500,000 women are diagnosed with cervical cancer every year globally. So this is one of the commonest cause. And if you go up through the pyramid, then you see the anal cancer, oropharyngeal cancer, and penile cancer. So in Malaysia, we don't have a lot of data for men in terms of oropharyngeal cancer, penile cancer, but the data is increasing. So we would see more data inside that. So worldwide, it has been estimated that 1 out of 20 human cancers for both men and women are due to HPV virus. Now, I just wanted to now to talk a little bit about cervical cancer because that's where the burden is. So let's look at cervical cancer first. Now, this is the advanced stage of cervical cancer. This is a cervix section. When you do a speculum examination, there's a vaginal wall and this cervix. You see the growth here, the fungating growth here, you see a lot of bleeding. So what happens if a woman gets HPV virus infection? It's not cancer yet, it's infection. So if you get infection here, let's say we get it today, the infection, what will happen to us? Most of the women will clear the virus. Most of us will get the virus cleared because our own body, antibody will clear the virus. So that's why it pays to be healthy. So eat healthily to make sure we are robust, we can clear infection. 90% will clear the infection. So nothing happens to us. You have a little bit of antibody, but antibody to HPV virus, natural infection will come down. So let's say 10% will not clear the virus. So what happened? So within 2 years, you get continuing infection here. Some of us can still clear the infection, but some now will get cervical disease. Now, this is not cancer yet. This is cervical changes in terms of cellular changes. So we call cervical intraepithelial neoplasia 1. Type 1 means it's just very early stage. Now, it's not cancer yet. So some can clear, some now will go to continuing infection. We see here, it takes about many years, up to 5 years for it to progress to CIN2, the more advanced, 2 to 3. But it takes like 15 to more than 15 years, 10 to 15 years to reach cervical cancer. What does it mean? It means that for women, we can still screen for the HPV virus infection. So here you see this is a normal cervix. So if you screen for the virus here, you can still be normal cervix. So you do a pap smear, your pap, you can still be normal, but you still have the virus. So you will not be able to detect the virus, but we can do certain specific tests to detect the virus. So this is a normal epithelium. Now for it to reach up to the cancer, it takes many, many years. So only a small subset will reach invasive cancer. Therefore, for women, we can always screen to try and identify these cervical changes early so that we can treat. But what about for men? For men, we don't have specific screening methods for men. But let's say, because the same HPV virus do affect the anus for both men and women. Why is that so? Because in the cervix, there is a transformation zone. In the anus, for both men and women, in the structure, there's also a transformation zone. That means the change of cells between one to another. So therefore, the virus can affect this area. That's the reason why men and women can be affected by the same virus. So in anus, that's where men and women you can get anal cancer or changes initially and then leads to cancer. Can we screen? Well, we don't have a specific screening tool for this. In research fashion, of course, we can find them, but in screening tool we offer to everybody, we don't have such screening tool in terms of anal cancer or any other cancer from HPV virus. So when you look at HPV virus infection, so you check transmission. So for woman to male, because we acquire it mainly by sexual intercourse. So for men and women, the transfer from woman to man is a little bit higher, 12.3 per thousand per month. But if the man gets HPV virus, the transfer to woman is slightly less. But for woman, the transfer to the man is slightly less. By either way, both of them will be affected. Now, even the transfer from men to woman is slightly lower, but men has a higher HPV prevalence across the years. So if you look at women here, this is a study during when they did an R&D on the vaccine many years ago in the early 2000s. This is a HIM study looking at males, all types of male at different age group, younger male, older male, up to 70 years old. But you look at the female, as they grow older, the prevalence of HPV virus in female goes down. But if you look at male here, across the years, it has no changes. It remains the same. So the prevalence is higher in men, despite the transfer is less, but they have higher, probably due to sexual habits or because in women, as they grow older, their sexual activity may be less. But having said that, so if the man is the same, they can still transfer it to the woman. So when you look at the responses to HPV virus, so we say a woman needs to get HPV virus in 2 years, you can clear the virus. What about in men? Yes, they still can clear the virus, but they take a slightly longer time to clear the virus. So the chances of them having an infection longer is higher in men than in women because natural infection prevalence of antibody in men is slightly lower, especially to HPV 16. So I told you just now that there's low-risk HPV virus. So the low-risk HPV virus causes genital wart, which is what we call ketuat kelamin. So genital warts can affect both men and women. Now, this is again acquisition through sexual activity or through touch. Maybe sometimes there's no penetrative sex, but there is touch, genital touch. So more than 90% of genital warts or ketuat kelamin, as you see here, is caused by HPV 6 and 11. That is more than 90%, almost more. It's almost 100% is caused by this. This is the vulva areas in the female. This is the anal area in the male, anal areas also. And you see here is the penile. And if you look like it looks as if it's like a cauliflower-like lesions. They can be found in the genital areas. Now, the ketuat that you see on your fingers, they're not the same. There are more HPV 1 and 2, the one you sometimes collate, so they're not the same. So this is 6 and 11, this genital warts. So they like cauliflower, but what's the problem with it? So it's itchy, it can be painful, it can have vaginal discharge, it can bleeding. But the problem is there is no definitive cure. If you get genital warts, you can get it recurrence. It can go off, we can cut it off, then it come back again. You can apply medication, it can come back again. So that is the problem with HPV 6 and 11 causing genital warts. So now we know the cause. So we know what HPV infection can do to both men and women. So let's look at the data in Malaysia. What does the data in Malaysia says? So there are many studies being done in Malaysia. Let's look at cervical cancer. Why we keep on looking at cervical cancer? Because that's where the burden is. That's where the higher burden is. So in Malaysia, cervical cancer is the second most cause of female cancer between the age of 15 and 44 years old. So if you think it's in general, it's the third leading cause of cancer death. So if you look at here, so every day, you can diagnose women with cervical cancer, but the only problem is more than 40% of women who comes in with the diagnosis of cervical cancer comes in at a later stage. And most of the time at the later stage, you will not be able to cure them. So that can be a catastrophe. So if you look at the subtypes of HPV virus in men and women in Malaysia, so let's look at some data. Now, this particular study has been done by Professor Wu in University of Malaya many years ago. So she took women and men who are healthy. So the woman volunteered the cervical vaginal swab. They do the anal swab and the oropharyngeal washing. So in men, they do the same. So they have the anal swab, they have the penile scraping, and the oropharyngeal washing. So she wants to see what is the HPV subtype in Malaysia. So what did she find? Well, it's almost what is found in the West. HPV 16, she had about 14%. She also had 18, which is 70% of causing cervical cancer. But you also found the rest, 52, 58, 31, and so on. But you look here, 68 is also quite high in her study, but 68 is nowhere in vaccine. But if you look at 52 and 58, together, it's about 21%. That's pretty high in Malaysia. I will show you some data in the West. Multiple strain in this cohort, that means more than one type of HPV virus, is about 13% in that cohort. This is in female. So if you look at male, so what happened in male? Because male always say that the vaccine is for female because cervical cancer, I do not need the vaccine. So I do not have the virus. Is that true? That's not true. So in her study, she also looked at males because the males volunteer the oropharyngeal washing, the penile scraping, and the anal swab. So let's see here. This is the blue is the oral sample, purple is a penile sample, and the green, bright green, is the anal sample. So in men in that group this is healthy men, all walks of life. You still see here HPV 18, 6, and you see 51, 52, 16. So 18 and 16 is still mixed more than 30%, almost 32%. Anal sample still has substantial HPV virus subtypes, almost 14%. The oral sample is lower in this group. So meaning male also has the chances of harboring HPV virus infection. But let's look at the association, which are HPV subtypes are more positive in histologic diagnosis, that means causing cervical neoplasia. So this is in Malaysia, this data in Malaysia. So if you look here, HPV 16 is about 40% here. 52 is high, it's 22%. 18 is about 8%, 58 is about 9%. Then you have the others, 33, 31, 51, 55. So when you look at by 52 and 58, is more than 30% are due to 52, 58. This is infection causing cervical changes. It's not cancer yet. So let's look at cancer in our country. So if you look at cancer here, again, it's the same. 16, 18. So that's more than 50% already. cervical cancer in Malaysia is due to 16 and 18. But you look at 52, 58, 13.7%, that's almost 14%. So that's higher than the West. So this is oncogenic type. So this is in Malaysia. So this is the frequent HPV subtypes. So let's look at some other data. So this is more recent data. This is again by Professor Wu and her team. She's looking at the high-risk HPV genotype in confirmed cases of CIN2. So they look at the confirmed cases, women presenting with that. So they did a biopsy and they see. Again, it's the same, 16, 18, 52. Here, 68, 31. You can see 45 here. So among this group, we still see HPV, the high-risk HPV causing cervical neoplasia. This is one of the studies which was presented in the OGSM in 2025. This study was done by Dr. Melissa Lim. She's a pharmacologist in UniMas, Sarawak. She also wanted to look at cervical cancer association with HPV genotypes. So here, her finding is almost similar. But the thing here, you see here, the cervical cancer that comes at stage 3, stage 4, which is advanced stage, is about 60%. Only 15% is at the early stage 1. So that is not good because when you come at advanced stage, it's not curative. Most of the time it's palliative care. And the commonest HPV virus in her group in Sarawak was 16, 18, which is similar in the rest of the world, and 52. We also have the rest. So it's quite convincing in the study. Now, this is a study done by Ministry of Health, by the Family Health Development Division, again looking at the same thing. So they screen women from Wilayah Persekutuan, Negeri Sembilan, Kelantan, Kedah, and Johor. They screen more than 36,000 women with high-risk HPV screening methods. What did they find? So they find that 28%, 27% here is 16 and 18. But in our country, quite a substantial amount, which is more than 70%, are not due to 16 and 18. Why is this important? Now, it's important when you think about the vaccine afterwards, because we have higher non-16 and 18. So we look at this one. This is again the same. So this group was looking at cervical cancer. Just now they were screening. Previous one they were screening. So this is the oncologist looking at multi-center. They look at patients from UKMMC, HKL, Klang, and this is JS, and they had KB. And they look at 280 patients confirmed cervical cancer. What did they find? Same thing. They find 58, 52, 33 makes the most commonest HPV genotype. And here they also have the rest. They have 33, 18, so they also do. So it's more, but you take note that 58, 52 is still higher in this group. And in their group, they find that multiple HPV subtype is found more than substantial, more than 30% of their group. Now, if you look in a nutshell, let's compare the rest of the world. Is it the same with us or not the same? Now, this is just looking at HPV 52 and 58 in cervical cancer and high-grade cervical lesion. High-grade cervical lesion means CIN2, 3. Then there is chance going to cervical cancer. Now, you look globally, the rest of the world, HPV 52, 58 is only 7.4%. If you look at US, so it's only 4%. Australia is less than 1%. Let's look at Singapore, 15%. Malaysia is almost 20%. It's higher, 52, 58 in Southeast Asia. Malaysia, Singapore, Thailand, Philippines, and so on. This one, there's no Philippines, that's still higher. Now you see high-grade lesion, again, globally, 20%. But you look at Malaysia, almost 30%. So it's higher in our subset. So I've shown you what HPV virus can do. It can cause infection, persistent infection. If it is unchecked, if it's not treated, then it can cause cancer. So when you think about it, now we have vaccine, HPV vaccine, the only vaccine that can prevent cancer. Therefore, we can sort of create working towards a cervical cancer-free world because we have a vaccine. So what can we do? So let's look at cervical cancer elimination strategies. I'm going to talk more on the cervical cancer, but at the end, we'll just talk for a bit about men too. When you look at globally, WHO in 2020 made a global goal to reduce cervical cancer to a rarity. A rarity means not zero, elimination is never zero, to a threshold less than 4 per 100,000 woman years. Because we know that cervical cancer can be a public health problem, and now we can find a way to prevent it. So in 2020, the goal was, the target is by 2030, 90% of girls under 15 to be vaccinated. 90% to reach that. 70% of women who were screened positive with HPV DNA screening are not being screened by the age of 35 or 45, at least twice. Can you do pap smear? We'll talk about it in a minute. And 90% of those women who has been screened but has cervical disease now should be treated. So the number is 90, 70, 90 by 2030. Where is Malaysia currently? Malaysia currently, before the goal, 2020, the cervical cancer in terms of the threshold was about 7 per 100,000 woman years. So now it's between 6 to 7. We have lowered it down. But can we reach it by 2030, which is another 4 years down the line? So let's see what we can do. So the first goal, 90% of our girls less than 15 years old should be vaccinated by HPV vaccine. So what is HPV vaccine? We know that cervical cancer, anal cancer, oropharyngeal cancer, genital warts are caused by HPV virus. So now we talk about cervical cancer. And we know that HPV is a necessary cause, is a causation to cause cervical cancer, 99%. And if we have the vaccine, we should be able to help prevent this. So what are the vaccines? So currently we have 3 types of vaccine. We have bivalent vaccine that only contains 16 and 18. So if you remember what I said just now, 16 and 18 is HPV subtype, high risk subtypes. But because it's 16 and 18, and when this particular bivalent vaccine was approved, it was only approved for female, only for women. It's not approved for men because they did not have any participants in their research group in men. But this is what we call the bivalent vaccine. The quadrivalent vaccine or 4-valent vaccine contains 16, 11. This is 90% that cause genital warts, and also 16 and 18, 70% that cause cervical cancer, anal cancer, penile cancer, and so on. And the other vaccine is called nonavalent vaccine or 9-valent vaccine. 9-valent means it has 9 subtypes. It has 6 and 11 subtypes, which is the low risk subtype that cause 90% of genital warts. And it has 16, 18, 31, 33, 45, 52, 58. That's high risk for cervical cancer and also for anal cancer and also penile cancer. So this is 9-valent. So when we think about what is high in Malaysia in terms of high-risk virus, then we've got to think which vaccine to give. If we want to cover 16 and 18, then we give quadrivalent vaccine. But we know that in Malaysia, 52, 58 is higher. Therefore, we should think about 9-valent vaccine if we want to reach the goal by 2030. So what is the schedule at the moment? So when you look at scheduling, when the vaccine was first approved in 2006 in Malaysia, so the vaccine, then it was incorporated into the National Immunization Program in 2010 by the Ministry of Health. So initially it was 3 dosing, but now it said 2 doses of HPV vaccine recommended to anyone, the adolescent less than 15 years old. The recommendation has not changed. It's still 2 dosing by the CDC. So if you are above 15 for men and women, this is under 15 for both boys and girls. If you're above 15 for men and women, then you need 3 dosing. So how do we give it? So in under 15, we give at 0 months, then 6 months later. We can still give it 12 months later, but in Malaysia currently is given 6, 0 and 6. So if you give 3 dosing, so you give at 0 months, 1 to 2 months after the first dose, 6 months after the first dose, or you can give it even up to 1 year or even later after the second dose. So the same thing. So this is currently has not changed. So I will talk about one dosing in a minute. So when you look about immunization program that has incorporated HPV vaccine around the world, more than 194 countries has some form of HPV vaccine incorporated into the program. So in Malaysia, we are also incorporated it into our program. So in Malaysia, the HPV vaccine was approved in 2006, and the Ministry of Health, we started the NIP in 2010. So the NIP initially was given to 13-year-old girls in school, 2 dosing. Initially was given 3 dosing. Then they started to give 2 dosing in 2015. So initially they gave bivalent, and then they gave 4-valent, then they gave bivalent, because the focus is 16 and 18 to prevent cervical cancer among women by the HPV subtype 16 and 18. When you look at the uptake in Malaysia's program is very good. The uptake is more than 90%. We are one of the best NIP program around this region. But for the boys, they have to pay out of pocket. So the boys do not get the vaccine under NIP. So I think the Ministry of Health are working towards it to try and see whether or not we can get the boys. So here is 3-valent initially, the 3 dosing initially. When 2015 they have 2 dosing. And now, this is COVID, it stalled for a while, then they catch up in 22, and now in 2026, they give 1 dose. So now, the question is, 1 dosing, is it appropriate or not to give 1 dosing? So we have to rely on a bit of science, because when we do recommendation, we have to believe in some science. Let's see some science in it. So what is this 1 dosing? So this 1 dosing regime comes from the study in India. So in India, when they had the vaccine incorporated into the NIP, so they did a study between 10 to 18-year-old, and they were supposed to randomize into 2 groups, 2 dosing group, 0 and 6 months, and the 3 dosing group, 0 to 6 months. Remember, these are the between 10 and 18 years old. So in 2009, and they had it in 2009, but soon after, by 2010, within 1 year after that, the government stopped it. Why did the government stop it at that point? Because there was some concern and side effect in some part of the world, which was the causation. There was not any causation, there's no relation at all to the vaccine, but the government in India stopped it. So when they stopped the study, some girls got 1 dose, some girls got 2 dosing, some girls got 3 dosing. So what did they do? So they were very good. They followed up this cohort of 1 dose, the 2 dose, and the 3 doses. So to see what is the effect. So from the IAC trial, now the IAC trial data is more than 14 years already. They made the first publication in 2021 in Lancet to see the vaccine efficacy in terms of persistent infection. When we talk about persistent infection, you must remember this is not cancer yet. This is the cervical disease, which is a surrogate for cervical cancer. So they look at persistent HPV virus infection. So the numbers are quite big. So 1,600 in 3 dosing, 2 dosing, 1,600. 1 dosing, they had more than 2,000 girls. So what did they do? So if you have a 3 dosing, and they look at 16 and 18, the vaccine efficacy. Now, the 3 doses, you would expect a high vaccine efficacy, so it's more than 90%. So when you look at the 2 dosing, they gave it 0.6, it was still very high vaccine efficacy, more than 90%. But you look at 1 dose, it's still pretty high vaccine efficacy, more than 94%, reducing persistent infection. And their publication after 14 years, almost more or less the same. So SAGE is a group in CDC. They had a meeting in 2022 looking at whether or not we could give this 1 vaccine, 1 dose only, Because around the world, we know that there's not enough vaccine being given to these girls or to women. So they say maybe take at least one dose. So let's look at the overview of key evidence of one dosing HPV vaccination, because now we got to reflect on this because Ministry of Health has given one dose. And a lot of people are saying, is it adequate or not? So this is the evidence on there are many studies being done, but I did not put all the data for you because it might be very boring, very difficult for you to follow through. I'll just give you the summary of it. So in terms of immunogenicity, that seroconversion to antibody titers, if you look at 1, 2, and 3 dosing is similar, more than 97%, whether or not you look at different studies. So it's very high seroconversion. Now, you compare one dose versus 2 or versus 3 dose, the seroconversion is still high because you saw just now the vaccine efficacy in terms of preventing infection. When you look at persistence antibody, at the moment, the one dosing is about 14 years. There's still some persistent antibody, a slight drop. Then the 2 dose and 3 dosing, in the one dosing, there's a slight drop in antibody, but it's still pretty high because there is no comparison to say what is the level antibody that can prevent infection. But there is a slight drop, but still high. When you look at protection means vaccine efficacy. So you saw just now, if you one dose versus no dose at all, the woman don't get any vaccine, versus if you want one dose. In Kenshi study, they look at it, still vaccine efficacy between one dose, no dose is very high. When you look at one dose versus 2 or 3 doses, still more than 94 and 82%. But the issue is you can still give one dose because CDC says if you cannot give 2 dosing, you give 1 dose. But you must remember, this is for girls and boys under 15 years old. If you're above 15, well, we don't have absolute data for 1 dose. We still recommend 3 dosing. But take the first dose first. Think about the second dose and the third dose later because we know that it is not cheap, but take the first dose first. So in SAGE under CDC, they did say give one dosing regime. It seems that the efficacy is still high, but we do not know the efficacy more than that because we've got to wait for data. We got to wait to see whether they publish on reduction in cervical cancer in the next 10 years or so. If there is a breach, then they need booster. But by the time you give booster, it may not be that absolute protection. So when you look at here in terms of safety efficacy, in terms of the recommended initial 3 dosing regimen, then the data is more than 24 years already. It still shows efficacy is very high. There is no breach in terms of these participants in the study. And they also assess safety very regularly. There is no signal of there is no safety signal in the HPV vaccine. Mainly are mild adverse events like dizziness, syncope, headache, or local fever, and so on. So when you look at this long term in terms of 9-valent, the 9-valent was later, 4-valent was earlier on. So the 9-valent now is more than 15 years already. Still, efficacy is very high. You see, there is no breakthrough in infection in those group in the study. When you look at safety data, this is just a safety data. It's just, if you access the safety data in the CDC website, you find there is no safety signal. So when you look at real world evidence, now we need to see, does it reduce cervical cancer or not? You look at Sweden, they're now starting to publish on cervical cancer. You look at the unvaccinated cohort, the number of cases of cervical cancer is much higher than the vaccinated cohort. Why we say the vaccinated, you still see cases in vaccinated cohort. It depends on what vaccine they take and when they take it, whether they've been exposed or before exposure to sexual activity. So if you look at Denmark, similarly in Denmark, vaccination before 17 years old and vaccination between 17 and 19 years old still shows very high vaccine efficacy. So the number of events, cervical cancer is still very low. So if you look at Malaysia, let's look at Malaysia. We need to look at the data in Malaysia. So the NIP started in 2010. So in 2013, the amount of coverage of vaccine is very low, 10%. By 2020, they're already more than 70%. So if you look at the NIP data, when you see here the dark green bar here, 1618, you see there is a marked reduction in 1618. Initially more than 90% in 2013 to 2015, 2019 to 2030, 2020, still very good, more than 85%. But you look at this box here, the number of non-16 18 is increasing. It's more than 21% here and now 90%. So we need to think a vaccine which does not only cover 16 and 18. So let's run quickly in terms of the second strategies in terms of screening. Now, a lot of women do pap smear screening. Pap smear is still relevant, but the thing is pap smear do cytological screening. They look at cellular changes. You may not have cellular changes, but HPV infection. Coverage in Malaysia in terms of pap smear is still very low, still about 40% only. But it's still useful if you do not have HPV DNA test. So the most relevant is if I say HPV virus cause infection, cause cancer, then the most common thing to do, you should test for HPV DNA test. Because if you find that HPV DNA is negative, you don't have to do pap smear at all. You do the HPV DNA test, maybe 5 years or even in 10 years, the chances of you getting HPV virus leading to cervical cancer is very low. And this test is very highly sensitive. So it targets the HPV virus DNA. So if you are positive, about 10% of women will positive, don't worry because it's infection. This is not cancer yet. Then we can still do a targeted treatment. So it's a very good triage. So 10% we positive, we only follow up the 10%, we do colposcopy and we do treatment. So what we do? So in those women that's positive, if we can treat 90% of those women by subjecting them to referring to the gynecologist or the colposcopies, and they do colposcopy, they take biopsy, they take cytology, they treat at the same time, and we also offer vaccine, give follow-up. And the chances you get cervical cancer is much, much lower. So most of these treatment can be done in outpatient setting, only battery operated heat destruction of the cervical cancer, cervical infection, especially CIN2, efficacy is very good, more than 95%. No anesthesia, maybe simple anesthesia, and the woman do not need to come. So at the end of the day, we have the means to prevent cervical cancer. For men, you have the means to also prevent anal cancer or penile cancer by taking the same vaccine, the same HPV vaccine. So we can have a world without cervical cancer. We can reach less than 4 per 100,000 women years. We vaccinate as many women and men as possible. Of course, now we have reached the girls under 15, but we should also do a gender-neutral HPV vaccine. We should vaccinate boys. At the moment, boys have to pay out of pocket. We should do DNA test for every woman. Every woman now should do a DNA test. If you are sexually active, even once in your life, you should do a HPV DNA test instead of pap smear. If your HPV DNA test is positive, then you do a cytology like a pap smear, then you do a colposcopy, they look at the microscope, the biopsy, and they treat 90% of the time. Then we can reduce mortality by 30%. So in terms of the obstacle, the problem, so there are many challenges. So the affordability is expensive vaccine. So in UiTM, this vaccine is lower cost. It's not subsidized. You manage to get lower cost, but it's only for a limited time. So if you want to get the vaccine at lower cost than the outside and private, you have to come to Hassan. And sometimes men are scared to take the vaccine because you say, well, I'm only monogamous. The chance of me getting a problem is lower. True, but vaccine is to protect ourselves. So don't worry to take vaccine. We don't even ask you about sexual activity. There's a lot of misinformation about HPV vaccine. The side effect is much lower. We should solve this gender inequity. Boys should get the vaccine. Also, we should also screen everyone, but screening in under-deserved population also in Malaysia is a problem. Solution, we can have mobile clinic, self-sampling kit. So if I give you the HPV screening and you can do it at home, would you do it at home? It's simple. Then you can send it to the clinic, to send it to the lab yourself. When you get the result, you can see a doctor. This should be better. So we have the self-sampling kit, and which we can maximize, but not a lot of us use it. So we can also educate community, public, doctors, nurses, healthcare providers, and we have global collaboration in terms of exchanging of information, looking at data, uh, sharing of science and data also, and reinforce prevention. So we should engage, educate, and vaccinate. By 2020 to 2030, we should try to reduce the cervical cancer to a rarity less than for per 100,000 women years. We have the chance to eliminate cervical cancer. So we have a good vaccine until we give it vaccine to that person, the woman, the man, on the arm, until it gets into the woman, we will not be able to reduce cervical cancer to a rarity. So in summary, I hope for the last 40 minutes or so, I have covered about the HPV virus and what it can cause, and how cervical cancer can be eliminated through HPV infection. In Malaysia, because of 52 and 58 is higher, we should recommend vaccine that contains these subtypes of 52, 58. We have 3 different vaccine, bivalent, quadrivalent or 4-valent or 9-valent, but only one vaccine that has 52 and 58. So taking the vaccine does not eliminate cervical screening. You should still do a HPV DNA test, but less frequent. You can do it once in 10 years, 35 and 45. If you do it after 50 years old, you're HPV negative, you don't have to do it. If you do it at 55, you still want to do it at 55 years old or 60 years old, your HPV DNA test is negative, then you don't have to ever screen again. The chances you get cervical cancer is extremely low. Men also need HPV vaccination. We should have a one-stop center in Hassa where you give vaccine, where we screen, where we treat. And we can do it in Hassa at the moment. So we have the team here to help everyone. So I hope if anyone who's working in UiTM who wants to have the vaccine, please come to see us in the ONG clinic in Hassa. So thank you very much for that. And I'll be happy to answer any question.
Okay, baiklah. Seterusnya kita buka untuk sesi soal jawab. Sekiranya ada pertanyaan, boleh type di ruangan chat untuk dijawab oleh penceramah kita. Okey, Prof, ada satu soalan daripada Encik Muhammad Kariza Yunan. Adakah perlu membuat temujanji untuk mendapatkan perkhidmatan vaksin di Hassa dan nombor telefon untuk dihubungi?
Dia technically dia tak perlu buat temujanji sebab kita punya klinik di setiap hari Isnin sampai ke hari Khamis. Hari Jumaat kita tak ada klinik per se, tapi boleh juga kalau nak. Kita ada temujanji online. So Encik boleh buat temujanji online tu untuk membuat satu temujanji. Katalah kalau tidak boleh, kalau nak walk in boleh juga, tapi masalahnya kalau walk in kena walk in petang. Sebab pagi tu klinik tu sangat-sangat busy. Bukan tak boleh, tapi dia sangat busy, petang lebih baik. Tapi kalau dibuat temujanji online, boleh je datang pagi, tak ada masalah. Sebab kita boleh je bagi vaksin tu setiap hari. Tapi vaksin ni hanya yang discounted price tu hanya untuk universiti, so di UiTM saja. Kalau orang tu tidak bekerja di universiti, dan mereka perlu bayar the full cost of the vaccine lah. Dan nombor telefon dia, saya rasa nombor telefon tu boleh dapat di website. Kan? Kan Fazira?
Ya, betul Prof. Okey Prof, seterusnya daripada Encik Muhammad Nazmi. Can people with the ketuat, the gill at the finger area get the HPV vaccine?
Okey, soalannya sangat bagus. Ketuat di jari dia bukan disebabkan 6 or 11. Dia selalu disebabkan subtype 1 or 2. Dia tidak bahaya dan dia tidak senang menjangkit, dan vaksin tu tidak ada type 1 and 2. Vaksin tu dia ada subtype 6 and 11. 6 and 11 dia ketuat kelamin. Dia tidak ada di jari. Di jari tu dia bukan ketuat kelamin. So that one is ketuat biasa dan dia tidak di cover oleh vaksin dan dia tidak berbahaya. Yang kita kata tadi di cover oleh vaksin ni ketuat di kelamin, di alat sulit atau di kawasan kelamin tu lah, dan dia berbeza sedikit daripada di jari. Yang itu kalau kita ambil vaksin dia boleh menghindarkan ketuat kelamin because 6 and 11 tu lebih daripada 90%. Tapi katalah seseorang itu telah mendapat 6 and 11 atau 6 katakan dia ambil vaksin tu, boleh tak? Boleh. Dia akan mengurangkan kadar dia berlaku lagi. Recurrence tu akan kurang. So kita masih sarankan mereka untuk mengambil vaksin walaupun mereka ada HPV subtype virus. Sama jugalah kalau kita buat HPV DNA to woman, kita kata ada subtype 52. Boleh tak ambil vaksin? Boleh. Sebab kita tak ada subtype yang lain, jadi dia boleh menghindarkan daripada subtype yang lain tu. Dia sangat penting tu. So boleh ambil. Sesiapa boleh ambil sebenarnya. Dan saya tak cakap tadi bila, dari umur berapa. Kalau kita ikut guideline di Malaysia, kita ambil daripada umur 9 tahun ke atas. Kalau kita baca insert dalam vaksin tu dia kata 9 tahun sampai ke 45 tahun. Tetapi di around the world kita beri tak ada upper limit. Sesiapa pun boleh, tapi more than 9 years old to anyone, 50 tahun pun boleh, 55 tahun pun boleh, tapi kita akan cakapkan kita tidak ada data tapi kita tahu ia juga berguna kepada mereka yang melebihi umur 45 tahun. Sebab kalau kita tengok tadi kadar infeksi dengan HPV virus ni dia tidak mengenal umur. So yes, you can take the vaccine but not for the warts on your fingers.
Nampaknya program kita
Prof, saya nak tanya soalan in regards to our the HPV DNA test mentioned, is it only available in Hassan or it is already available throughout Malaysia?
Throughout Malaysia, you can do the HPV DNA test in Hassan also can, and in private clinic pun ada, GP pun ada, because they do the test macam kita buat pap smear juga. So kita ambil the cell dan kita hantar ke lab. Kita tak buat di Hassan itself, kita hantar ke lab luar.
Oh okay, so dia dah kira first line punya test instead of pap smear, or usually pap smear is done first before the HPV?
No. HPV, the recommendation is to do HPV DNA first.
Okay.
Not pap smear. So kalau you buat HPV DNA test and it is negative, you don't have to do pap smear, no? So HPV DNA test negative, you don't even have to do next year HPV DNA. You do 5 years or 10 years later. Because if it is negative, meaning you don't have the HPV virus. So let's say next year you have the HPV virus, you still take another 10-15 years becoming cancer. But if you're HPV positive, that's where we were sent to the colposcopist, gynae-oncology. They look at the camera, they look at the cervix, then they ambil biopsy. Dia macam pap smear lah, dan kita ambil cell, tengok cytological changes. You can get HPV positive, tapi tak ada changes in the cervix at all. Then you follow up every year with the same pap smear and colposcopy.
But the HPV DNA test is done yearly? Or?
So sorry again?
The HPV DNA test is not done yearly like pap smear, right?
No. HPV DNA test you can do every 10 years. Tak payah yearly, or you can do every 5 years. Tapi 5 years dia terlalu dekat. Kalau katalah tidak ada dana ni, people tak nak bayar kan, dia buat 10 kali 10 tahun lah. Macam di Ministry of Health dia buat 35, 45. So katalah you nak buat 55, boleh aja. You nak buat every year, boleh aja, tapi it's no point. So you buat 5 years, boleh. 10 years, boleh. So it's a strategy by the country. So I think in some countries they do every 5 years. Malaysia we say 35, 45 because there is limitation in resources. But let's say you want to pay yourself, you can do every 5 years. So it's negative. So if you do 50 years, kata at 50 years you do negative, technically, should you do again, you don't have to do. The chances you get cervical cancer at the age more than 60, less than 1%. Very small. So, tak perlu buat pap smear. Tapi kalau tak ada HPV DNA test, of course we advise you to do pap smear. Pap smear is a secondary test because you can get a negative smear, normal, but you can get a HPV virus infection. Dia tak akan nampak di pap smear.
Okay, Prof. Thank you.
Nampaknya program kita telah sampai ke penghujungnya. Pihak unit latihan ingin mengucapkan ribuan terima kasih kepada Prof di atas kesudian untuk berkongsi maklumat pada hari ini. Moga taklimat yang disampaikan bermanfaat kepada semua warga UiTM. Dan terima kasih juga diucapkan kepada semua warga UiTM yang menyertai taklimat pada hari ini. Pautan jam latihan akan diberikan di ruangan chat. Kita akhiri program kita pada hari ini dengan tasbih kafar dan surah Al-As. Terima kasih Prof. Terima kasih semua. Assalamualaikum.
Waalaikumsalam. Thank you so much.
Okay Prof.
Bye.